Hi all, I'm Dr. Tahra Ibrahim, specialty doctor in emergency medicine. Today I'm going to teach you a small procedure, lateral canthotomy. So I'll be telling in 7 headings: indication, contraindication, complication, how to avoid complication, and preparation of the preparation and procedure itself, and the post-procedure management. So indication for the lateral canthotomy is the orbital apex syndrome. That's an it's an ocular emergency that manifests with rapid progressive vision loss, increased intraocular pressure, and which will lead to decreased extraocular motility and pain in a patient with a recent eye or orbital trauma or surgery. And due to the retrobulbar hematoma or severe edema, there will be increased intraorbital pressure, and this intraorbital pressure can cause intraocular pressure to rise, and this compresses the orbital apex structures, that's optic nerve and the vascular supply, the blood vessels. So if it's untreated, this can cause permanent loss of vision. So lateral canthotomy can help to relieve the intraorbital pressure, and thus it can preserve vision. If there is any signs of indicating orbital compartment syndrome or orbital apex syndrome, and if there is any indication of orbital apex syndrome from the CT. Now, about the contraindication, only one absolute contraindication for lateral canthotomy, that's suspected globe rupture. So the patient will be having irregular pupil, hyphema, shallow cornea, and leak of aqueous humor. So what are the complications of the procedure? The iatrogenic trauma to the eye, that is the damage to the lateral rectus muscle, lacrimal gland, or the lacrimal artery or the lids. And second one, hemorrhage and infection. Next is how to avoid complications. So the technique itself, like if we are cutting infra-posteriorly toward the lateral rim to avoid injuring the levator muscle, lacrimal gland and the lacrimal artery, which are always located superiorly. And how to avoid infection using sterile technique, and bleeding can be prevented by using a hemostat or using a lidocaine with epinephrine. Now about the preparation. Preparation we usually tells preparation of the patient, preparation of the doctor and the nurse, preparation of the equipments, preparation of the patient position. Supine, patient should be positioned supine, stabilize the patient's head and eyelids. Then equipments. We should gather all our equipments in a sterile tray, and these equipments includes our gloves, sterile gloves, gauze, drapes, antiseptic solution, ocular anesthetics, topical and local anesthetic 1% or 2% lidocaine with epinephrine, and small needles, injection needles, and small syringe, about 3 ml syringe, and ophthalmic antibiotic ointments, and a hemostat or tooth forceps and iris scissors. For the preparation of the doctors and nurses, we should wash our hands, wear PPE. Now the procedure itself. So before doing the procedure, we should identify the landmark. Usually the landmark is the lateral canthus. The lateral canthal tendon has two branches, a superior and an inferior branches. So if you're cutting one or both, this will loosens the eyelids and allows the globe to expand out of the orbit, and thus it relieves pressure on the eye. So first step for the procedure is identifying the lateral canthus, inferior lateral canthus. Usually we will not incise the superior canthus because usually the lacrimal glands are present in the superior canthus. So then the procedure. You should first identify the lateral canthus, inferior lateral canthus, then cut through the eyelid until the orbital rim. Before that, we should do the sterile, prepare the skin with antiseptic agent such as povidone, iodine, or chlorhexidine. Then we should apply the local anesthetic 2 ml lidocaine containing epinephrine into the lateral canthal incision site. Then we should make an incision from the lateral canthus. 1 to 2 centimeter incision should be made, and the last part of the incision should be at the last part, the border of the eyebrow. And then use a needle driver or hemostat to crush the tissue from the lateral canthus to the rim of the orbit for about 20 seconds to 2 minutes. So crushing this tissue helps to minimize bleeding and makes it easier to see where to cut when there is extensive traumatic edema. Then use the iris scissors to cut from the lateral canthus to the rim of the orbit, as I told earlier, about 1 to 2 centimeter. That is known as canthotomy. Then cut the inferior and sometimes the both crest of the lateral canthal ligament. Okay, and lift the portion of the lower eyelid. With the scissors pointing away from the globe, identify and cut the inferior crest. Strumming with the scissors may help identify the inferior crest. If the tendon is still intact, you will feel a twangling like a plucked string. So after cutting the lateral canthal, inferior lateral canthal ligament, we can see that the lower lid will be moving freely. Okay. Then after the post procedure, we should check for the symptomatic improvement. And second one, check the IOP. And if the patient usually symptoms will resolve by 10 to 15 minutes. So if there is no improvement or if the IOP is still raised, we need to cut the superior canthus. Okay. Then here the most important thing is time is vision. And if you have a suspicion of orbital apex syndrome, do it within 12 to 15 minutes, because if you are waiting for confirmation, this will lose the vision. So that's about the procedure. After the procedure, we need an ophthalmology consultation because this needs to be repaired. Now, post-procedure management, apply the antibiotic ointment to the eye and cover with sterile dressing. Then check the IOP. Usually we can use a tonometer, or you can use digitally to measure the, we can digitally palpate and measure, you can check, compare with the other eye to see whether there is any improvement. Then we should dispose the waste in the sharps, should be in the sharp bin, and document the procedure in the patient notes and printed leaflet to the patient giving an advice to avoid straining, and the patient should apply ice packs for several weeks. So as I told earlier, ophthalmology consultation should be done for the repair of the lateral canthus. This is about the lateral canthotomy. So this is an important ophthalmic emergency. So we can I'll revise it. So it's indication orbital apex syndrome, contraindication if there is suspicion of globe rupture, complication, damage, mechanical damage to the tissues, and infection and hemorrhage. How to avoid? Using the position cutting technique itself infero-posteriorly, and the use of sterile technique and use of hemostat and adrenaline with the lidocaine. Then the procedure itself, identify the landmark, then cut do the incision, apply do the local anesthetic, incision, then cut the lateral inferior canthal ligament, then post procedure management and monitor the patient. So this is about lateral canthotomy. So thank you. If you have any doubt, please email me at tahiraibrahim 87@gmail.com. Thank you.